Hello friends, I am Dr Sourabh Patwardhan from Nandadeep Eye Hospital, PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well.
Hello, I'm Dr. Sourabh Patwardhan, and this is a video where I'm going to tackle a intumescent cataract with extremely shallow AC, which is seen pre-operatively. You can see the AC depth is just 2.16, and if you reduce the corneal thickness, it appears that it's just 1.5 or 1.6 millimeter, which is very narrow. So in these cases, we generally do not dilate these patients preoperatively. Intraoperatively, we use diluted adrenaline to dilate this pupil. So it must be realized that the pupil may not dilate at all during the surgery as well if the iris or pupil is actually non-dilating. I have stained the capsule here, but as you can see, the stain is very poor. So I should have kind of waited little bit longer so that I get a good stain. And getting good stain in these cases is useful not only for visualization, but it also makes the capsule a little bit kind of brittle, so that the chances of it running away kind of goes down. So here it's very classical intumescent. You can see after making the first cruciate incision, there was some fluid egress. But most important thing is to remove this liquefied cortex using 27 gauge cannula. You can just use attached syringe to suck this cortex out, or you can attach it to the phaco aspiration tubing as well with the adapter. You have to aspirate it from both the sides to remove these fluid pockets. And you can see the anterior capsule here is actually flattening. So once you have done that, milk the peripheral liquefied cortex here using the visco cannula itself. I am injecting the Hylucoat here and flattening the anterior capsule further. Once the anterior capsule is flat, you just have to follow the standard technique of capsulex. Here the forceps is not good. You can see it's not holding. So if you find the trouble, just change the instrument. I found many times that our trainees tend to struggle with if the with the instrument. If it is not good, just change it to a better one. And once you can see the capsulex forceps now I'm using, you have to hold the tear very close to its end. If you hold it away, in these cases there is a chance that it may run away. Grab and re-grab every 2 clock hours in these cases. So if in normal case you are grabbing it again and again after 3 clock hours, here the threshold should be less. You can see the later part I re-grabbed it after maybe more than 3 clock hours, and that's the reason why it became little bit bigger on that side. So I think just watch my video on how the vectoral forceps work when you are using the capsulexis forceps. And here of course I had removed all the intumescence initially, so that's why I didn't get any extension of the capsulexis. Now rotate this nucleus multiple times. If you see, I have not done any hydrodissection because that's not needed. The nucleus is already free from the bag. But you have to rotate it multiple times so that the cortex which is in the periphery gets loose, because in these cases you will find there's a lot of cortex many times left at the equator of the bag, so that kind of gets loose if you rotate the nucleus multiple times. Here the nucleus itself is soft, so you have to use very low power. You can either do trench divide or you can do chop, like I will be doing chop here, but use very low power. Don't use very high power because the chances of punch through this soft nucleus is very high. So intumescent cataract, in fact, treat it like it is a grade 1 to 2 cataract. Don't even if it looks mature, it's not hard enough. So use a low power, low energy, and once you have done, it's a usually very brittle nucleus, so the division is actually quite easy if you have done enough trench or you have got enough hold on this nucleus. You can just easily crack into multiple pieces and then use the vacuum to phacoaspirate it. You can see I am using my bevel sideways here, and wherever the tip is positioned, that is the area of maximum influence of the vacuum. So bring all your pieces to that side. So here, if the bevel is on the left side, I'm going to bring all the pieces to my left and just aspirate it. So this is the cortex aspiration. As I was saying, in the equator many times there is a lot of thin these sheets of cortex which are there in these intumescent cataracts. So make sure you remove those. If you can't remove those in the initial go, put the IOL, rotate it one time so that it kind of dislodges all the that cortex from the equator of the lens, because you don't want the cortex hanging there post-operatively in the anterior chamber. So just make sure you remove all the that thin cortex in the at the equator of the lens. Once that is done, I think I will be placing the IOL. Here I am using a toric IOL. So you will find that initially these patients, they may not be able to fix on the light because they can't see because of the mature cataract. But once the nucleus is taken out, they can see well, they fix well, and it becomes easier. So in the initial part, you may have to fix the eye properly using the second hand instrument. This is the Renner EMB toric IOL going into the bag, and it's a toric IOL, so I'll be using the Callisto markerless system to place the IOL according to axis. So all these cases where you have intumescence, you have very shallow anterior chamber. So generally, if the anterior chamber depth is below 2.3, I don't dilate it before the surgery. I dilate it only intraoperatively. Or if I want to dilate it before, I have to do a laser PI and then dilate. Otherwise, they have a high chances of angle closure attack. Another important thing is that always in these cases, be ready with pupil expansion devices, be ready with capsular tension rings, because you were not able to see the lens properly preoperatively. There is always a chance that there might be surprises like zonular weakness or non-dilating pupil in these cases. So it always helps if you are prepared, well prepared for these kind of cases. The wound is well hydrated. Now the patient is fixing quite well, and that's almost end of the surgery. Just couple of hours post-operative, you can see the cornea is crystal clear. Patient has already started seeing. Patient is extremely happy. So make sure that you up your game and make sure your results are predictable as in this case. Thank you so much.